Good morning and welcome to the live streamed version of the London Ambulance Service Public Board meeting of the Directors. So a particular welcome to members of the public who have joined us by live stream. We have apologies this morning from Jill Anderson and Aline Smith. Can I ask board members if we have any declarations of interest? I'll take that as a no. Thank you very much. So I turn now to the minutes of the public meeting held on the 28th of July. I'll do it page by page. So are there any points of correction on page 1? Page 2?
Chair, on page 2 at the top, I think it says the minutes of the meeting held in public on the 28th of July were approved as an accurate record. I think
and they couldn't have been, could they? No. So the meeting before was May, wasn't it?
Yes.
So could we ask you, Simon, outside to correct that? Well spotted, Amit. Thank you. The rest of page 2, page 3, page 4, page 5, 6, page 7, page 8, page 9 and page 10. No. So if I can take those as a correct record of the meeting and move on to matters arising, the action log. So we have 3 items on there. The first one is deferred, which is the feasibility of establishing a London Ambulance Service Youth Forum. I know it was deferred because of COVID, but Anthony or Karim, do you want to comment on that, of what our plan now is? Karim, Professor Brohy, and Anthony, who wants to go first?
Yeah, Anthony and I have been discussing, and I know Anthony's drawing up some structure around this. See, Anthony's come on now, so he might want to add some detail, but it's on track. Great,
thank you. Anthony, do you want to add?
Yes, Chair. So it's part of the People and Communities paper that we're presenting later on.
Good, perfect. Thank you very much. So does that mean we can close it?
Yes, it does, Chair.
Excellent. Let's close that action then. Thank you. But we will look forward to picking it up regularly under your reports on user engagement. Thank you. And the other 2, so their dates were today, actually. So the abstraction, Kadir, just tell us a bit about that. Just remind us, please. Abstraction rates for training. Where have you gone, Kadir?
Sorry, Chair. We've included an update in the papers that just sets out, or we should have provided an update to, I think the query was raised by Fergus in terms of a breakdown of abstractions and how they are, how they're counted, how they're understood. I think Nella had the detail of that. Okay, so we can close that unless something is raised through your paper. And the last one, Fenella. Finite cost of the CES service. Remind us all what the CES service is, and just to remind everybody, we're live streaming, so our abbreviations, which are many and multiple, we need to remember to say what they are. Thank you. Fenella.
So this is the Clinical Education and Standards Service, which provides all of our clinical training to colleagues right across the organisation, and has recently taken all clinical training from 999 and 111 call handling right through to the most advanced paramedics under one umbrella. We have provided a one-pager which breaks down the amount of training for each group of frontline clinicians by hours and approximate cost, and then the non-pay and pay expenditure as we know it today. As we increase our numbers and we change how we are providing our training, this will continue to be reviewed.
So is there an absolute amount that it costs today?
So the non-pay expenditure is 2,500,000. The pay expenditure is £11,666,785.
Thank you. And will we be picking that up in People and Culture Committee, Jane?
There wasn't a plan to, but I can take it as an action.
I suppose what's going through my mind is how much good organisations spend on training their staff, really, and whether we think that's reasonable. So that would be just over 2% of what we think our revenue for this year is going to be. And is that benchmarkable? Lorraine?
I don't think this year is going to be a good year to benchmark, but we might be able to go back and look at whether it probably is up to 5% of revenue, I would think.
So I think when we're setting our strategy and our business plan, it's something for us all to keep in mind. What would a good organisation spend on training and development rather than finding we can't afford to do it? And that would be encompassing modern methods of training. Okay, thank you. So are we satisfied that that one is closed, or do we need to keep that, or can it be picked up elsewhere? Lorraine, what's your advice?
No, I think we can close that and pick it up later.
Okay, thank you. I think it's important we don't lose it. Thank you very much. So I'm now turning to the report from the chair, which I will take as read. There are two things that I need to bring to your attention. One is the paper attached, which is the proposal to revise how the staff and volunteer advisory panel is set up, a new terms of reference. And this is very much in response to what we're hearing from staff, building on Black Lives Matter, race equality, and the work that Garrett is doing on culture, to make sure that staff feel able to speak, that aren't hampered by having managers in the room. Obviously, we will need the chairs of the various diverse groups and staff and volunteer representatives. But I wonder if people have had a chance to read that and whether any questions or whether you're ready to approve that. And it's difficult to tell if people want to ask any questions or are trying to get off mute. But the one question we talked about in the point that we did have, we had a co-chair in the first proposal, and I think we want to discuss whether we think it is a good idea to have a co-chair. And this was building on the member of staff, Andy Heward, who wrote a paper for us initially, and the co-chair was about how we could have a staff member attending board meetings, and that arose from the time when we were no longer having somebody on the board as a paramedic. However, what I would say is, as you know, our proposal is to have a chief paramedic, but also this is not, their role won't be representative, and our organisation employs a lot of people who are not just paramedics, not just, I don't mean, but not frontline people. So it's whether we feel that it would be wise to have a joint co-chair that could attend Part A of the meetings. Do people have a view on that? Garrett, do you have a view? No view?
I'm experiencing a few technical issues at the moment, so I haven't picked all of that up. But no, I don't have a particular.
I think it's, well, my personal view is that it's quite a good idea when it gets going to have a co-chair to show staff that they are welcome. Mark is saying yes, but I think we need to get it realigned. Lorraine's saying yes too. I think it's a case of making sure this is truly where staff can say in a confidential way how they're feeling about issues that impact them in their work. It just distinctly is not about management. It distinctly is not cutting over management or trade union activity or anything like that, and it certainly won't be about individual cases. Yep. So I think we will, on the basis of what people are indicating, go with a co-chair when we set it up. Thank you. So can I take that as an approved way forward? Yep. Thank you. Anthony, are you on the call still? Anthony, do we have you? Are you? I can hear you, good. So this group will work in concert with your stakeholder group. Are you content with that?
Yes, I am, Chair. We will be having a co-chair for the London Ambulance Service Public Patients Council. I suppose my advice would be to make sure that they get a good induction, one in terms of the background of the organisation and stuff they might not know, but also how to be a chair. It's not, as you'll know, chair clearly, it's not necessarily an easy skill.
No, it's a different sort of role. Okay, that's helpful, thank you. So approved, and we'll have a co-chair. And the other thing that isn't in my report, because it happened at the end of last week, is Kadir and I met with the London Council meeting to do with low traffic neighbourhood interventions. And our starting point that we made was that from a London ambulance perspective, we must always put patient and staff safety first. But in that context, we agreed that what they're trying to do is beneficial for the health of the population, particularly low emissions, asthma, that sort of thing. So we committed to working with them to aim to try and have some joint communication and to build a relationship with them that will also help us when we wish to implement our vision on the future of ambulance sites. So we agreed to meet quarterly, and there's a note that I can send round to you that has been written up for us. Kadir, do you want to add to that?
Only that it was a really, really productive meeting between, obviously, yourself, Heather, as chair, and leaders, local authority council leaders across London, and a commitment really to work together, and for our assistant directors of operations to be the point of contact for any local authority chief exec or their executive team in any discussions around any measures that they're putting in place, and for us to work collegiately, collaboratively with them to ensure that our patients and our staff are protected while supporting the wider agenda around public health and traffic management.
And we also confirmed that although journey times were taking a little bit longer, there had been no adverse events, that we record everything on Datix and would be keeping a check on that to ensure that nothing compromises safety. But there had been quite a lot of compromises in what the boroughs had wanted to do and what they've done, because they have been in discussion with Garrett Kadir and his team. So we did find it positive, and we will keep that relationship going. Any questions on that, or any questions on the rest of my report? No. Okay, then thank you. Then we move to the Chief Executive's report. Garrett.
Thank you, Chairman. I think my report is largely as tabled. The only thing I was going to, I suppose, particularly highlight, because I think it deserves highlighting, is on the penultimate page, just to recognise the work of the external communications team, who've been shortlisted for in-house Team of the Year at the PR Week Awards in 2020, which will be a slightly unusual event compared to normal years, with no real physical event taking place. It'll be a virtual event, but we wish them best of luck. And I think it reflects a huge amount of work that team have done over the last 12 months in responding not only to all of the day-to-day media inquiries and so on that come with the organisation, including 2 major incidents, but also a number of successful or important campaigns, particularly around tackling violence and abuse against our staff, both physical and verbal, which kind of leads me nicely into their other huge achievement this year, which is the work to support the filming and now the broadcast of the current series of the BBC documentary Ambulance, which I know colleagues on the board will have seen and be aware of. The third episode of that is on BBC One tomorrow night, and does focus in on verbal abuse of our staff in call centres and control centres. So it's another opportunity to really highlight that whilst it's a very small minority of our patients and callers that do abuse our staff, that it's totally unacceptable in any situation, and that we take the strongest possible measures to find and prosecute wherever possible any perpetrators. We work incredibly closely with the Metropolitan Police, with the resources they have through their Operation Hampshire organisational setup, and you will have seen recently in the media that we did some publicity surrounding the appointment of the 2 new violence reduction officers that we've got supporting our crews on the ground and our colleagues in control rooms and call centres, all of which I think will get highlighted in terms of the episode on Wednesday night, but also in terms of the work we're doing. And we, I think, all of that, none of that happens by accident. It happens by a lot of hard work by the communications team. And I think it's right that they get recognised. So that's really all I wanted to say by way of introduction to the report, but any other questions on any of the content, obviously, very happy to take them.
Okay, so I'm sure all of the board would like to congratulate the external comms team for being shortlisted, and we wish you luck. Let us know. Okay, any other comments on Garrett's report that anybody wants to pick up now that doesn't occur later on in the papers? No. Okay, then we have noted your report, Garrett. Thank you very much. We now move then to the Chief Operating Officer report. This is an item we started last month. And Kadir, we look forward to hearing from you.
We got caught out by not unmuting, but there you go.
It's all right.
Thank you, colleague. If I take the report as read and just provide some highlights, I'm happy to take questions, comments, colleagues. I'm really pleased to present the second Chief Operating Officer report to the board. The executive summary sets out kind of the highlights in the report. We continue to provide and deliver strong operational performance, meaning that we are maintaining nationally required response times in getting to patients, depending on the criticality of their conditions, and ensuring that our response times and the care that we provide, therefore, is appropriate to the levels of illness. So strong operational performance, while we also continue to prepare for winter. Alongside preparing for winter, and I recognise we've got a high-level winter overview here. There's more to come in the coming weeks. We continue to monitor the levels of COVID prevalence in the community and the impact that has on our 111, 999 and ambulance services. While we continue to monitor that and respond to those levels, which we have seen increase slightly in the last 4 weeks, we are also putting in place measures to be able to ensure that our estate, our infrastructure and our leadership is secure and fit for the future in order to maintain operational resilience in the organisation. And there's an example of that in the logistics unit business case that's further on in the agenda. We continue to make appointments substantively in order to reduce our reliance on interims where we do have them, and I'm really pleased to be able to report that we've appointed a head of fleet substantively to the organisation, who comes with a track record and a level of experience in the fleet industry, and a huge asset to the organisation. We've also appointed a head of estates, which I'm not able to announce yet while we work through the various processes, but really positive appointments which have been vacant and filled on an interim basis for a number of years now, so really positive. A few other highlights, colleagues, before I open for questions. We've achieved a significant milestone in the organisation in terms of going live with our pilot for the electronic patient care record. So we process over 1 million pieces of paper in the organisation a year in relation to our paper records for any patient contact we have. And we went live in August and early September in piloting the electronic patient care record. We have 150 frontline ambulance crews who are now processing their patient contacts through a digital app on their iPad and handing over patients at hospital digitally. as opposed to handing over a piece of paper. In the next couple of weeks, we expect to go live with the full rollout of electronic patient care record alongside the training that we're providing to our staff. So by the end of this calendar year, we are hoping to have the vast majority of our staff using the electronic patient care record and the organisation moving away from paper as a means of recording patient details and patient notes. So a huge achievement there, and I'd like to thank colleagues who have been part of that. And we continue to work on the development of primary care networks. I know Garrett picked up that in the Chief Exec's report, but we're hoping to go live with a trial in Merton this coming. There's some highlights, but happy to take questions, comments.
Thank you, Kadir. Karim, then Jean.
Yeah, thanks. I wondered if you could speak specifically on the level of COVID preparedness we have for second wave, which it looks like we're in. It might plateau, it might increase exponentially, and just specifically about where we are now, and items of specific concern like PPE and things.
Yeah, absolutely. Thank you for the question. We've got a number of systems and processes and resources in place to be able to respond, to be able to monitor and respond to any COVID pressures that we may experience. On a daily basis, Karen, we meet through the daily senior leadership team meeting. So at 12:30 every day, we review operational pressures that we've experienced the day before, and look forward to what the remainder of the week looks like. And it's at that meeting that we review levels of activity across the organisation, be it in 111, in 999, and in ambulance services, and what proportion of that may be COVID related. We also review the projections as to what that activity may look like in terms of in the coming days and weeks. Not only do we look at and review the levels of activity that we're currently experiencing, we also have a check-in in relation to our fleet availability, our PPE stocks, and any issues around our workforce in terms of sickness or isolations. So on a daily basis, as an organisation, we live and breathe what the situation across London looks like, both externally, but also what it means for us operationally within the organisation. And it's through that process that we then tweak and mobilise the level of resources that we need to be able to put out to maintain a resilient response. In the appendix of my report, and alongside kind of our winter preparedness, we've set out as an organisation to be able to be ready at any time to respond to up to 10,000 999 calls. And so what we've done is we've broken down across 111, 999 and ambulance services what levels of the resource we need to be able to mobilise, how we would mobilise it, how long it would take to mobilise, and we keep that under review on a daily and weekly basis in order to make sure we've got the capacity and capability to be able to respond to any waves or peaks of future demand. An example being, Karim, at the beginning of September and the start of school, we started to see some operational pressures in our 111 services in relation to volumes of calls that were potentially COVID related. We were able to very quickly mobilise additional resources in our 111 services in order to meet that demand and make sure that we were providing the right levels of patient care. And that was because over the summer, while demand dipped down, we've grown our workforce in the 111 service both substantively and flexibly through bank arrangements to be able to mobilise resources at short notice to be able to respond to increasing demand as and when we see it. So at the beginning of September, we started to see a peak in calls we mobilised resources, and we are now back to responding to those within national standards. We did that, although it.
Kadir, sorry to interrupt, but just, I guess, very specifically, I guess I get you've got process, but specifically, will you have enough staff? Will you have enough PPE? Will you have everything when the second wave comes? And I get, based on the ambulance programme last week, if you're getting 10,000 calls and you have to go to paper in the EOC, what would that look like?
Yeah. So I'm working on the basis that, so although we've got very, very robust measures in place to be able to go to paper, we've just completed in September and assured by Sheila and the Logistics and Infrastructure Committee a system which has completely updated the hardware in order to make sure that that is more resilient. So I'm working on the basis that our infrastructure in our control rooms is much more resilient than it has been historically, and should be able to manage additional call volumes and additional capacity. One of the reasons for doing that upgrade was to be able to create much greater capacity on that hardware to be able to have more call handlers on the CAD. And historically, we've been limited by how many call handlers we can have. So if we go to 10,000 calls, we've got arrangements to be able to mobilise our call handling resource to be able to respond to those, to be able to respond to that demand. And I can give you an example of what that would look like. We've got a range of measures. If you look at, it's page 17 in my report, but you've got a range of measures from working with other ambulance trusts to agree buddying arrangements, to increasing our clinical capacity in terms of how we triage calls, to putting in place process arrangements so that we can mobilise second-year students to take a volume of calls through a decision support tool, etc., etc. So there's a range of measures that we can mobilise and that we keep under review to be able to manage demand as we see it. I think our performance to date since the peak of COVID demonstrates that we've now mobilised a set of measures that can manage waves and peaks in activity, and that's why I think we've got strong operational performance across ambulance services, 111 services and 999 services.
So
Makes sense.
I think it's really important that we spend time on this item, because we're reassured you've got a plan, but we need to say, where is that assurance? If I just pick one, Karen started with asking about how much PPE we've got. How many weeks PPE do we have? Is that that's a bit of bouncing you, Kadir, but if there was, if we had a peak starting tomorrow, how many weeks stock have we got as of today? Do you know?
So I can't tell you that at my fingertips, but I can tell you that ideally we'd like to maintain up to 4 weeks worth of PPE. The challenge we have around PPE is currently our constraints in terms of our estate to be able to store that. The other challenge we've got with PPE is there's now a national process for PPE, and there's a real challenge within the NHS that we shouldn't be storing more PPE than we need, because that needs to be nationally managed.
Right. Let me just, I know Jane and Rommel and Sheila want to come in. Is it, Jane, is it about this item?
Yes, it was, and Kadir's virtually answered my question.
Okay.
Mine was more about have we kept all of those people warm that we brought in from the airline industry, etc., so that we really can ramp up rather than having to go and re-recruit?
Yes, so all of our bank arrangements remain in place. If I just give you an example on some of the substantive, so in 111, for example, our health advisor capacity in South East London in February, we had 92 substantive health advisors, and in North East London, we had 94 substantive health advisors. In September, we have 139 substantive health advisors in South East London, and we have 113 substantive health advisors in North East London, and we continue to grow that substantive capacity as well as maintain bank arrangements with agency and kind of professional providers. So we are both growing our substantive capacity in the ones, in the nines, and ambulance services, as well as maintaining flexible resource through bank and volunteers.
Okay, thank you. Rommel, was yours on this item? Sheila's probably, it's about the IT, I suspect, and then Lorraine. Rommel, is it on the
Yes,
same?
thank you, Chair. Yes, in a similar vein, I'm pleased to see the arrangement with the London Fire Brigade, and I think you've got a pool of, I think I read 400 FTE. I just wondered whether this arrangement is being formalised, just thinking about, the new normal and how we might be just needed to be called upon.
It's a really good question. So just some context. The arrangement that we've had in relation to the fire brigade up to 9 was we had rostered up to 300 between 300 and 400 firefighters actually rostered in our rosters and moving through the organisation and providing frontline ambulance services. Obviously, that arrangement has come to an end because those firefighters have been asked to go back to their day-to-day duties. What we've been developing with the London Fire Brigade is an MOU that allows those firefighters to be part of our bank arrangement, and for us to be able to those as we would over time of our substantive or our bank staff. That's an arrangement that we've picked up and agreed and would allow us to have rotating through our rotas somewhere between 75 and 100 at any given time. Okay. The MOU is at the moment with the LFB to be signed. I just need to be clear about that.
So it isn't in place yet. So there's a process, but we're not assured yet that they'll be available.
Well, the MOU, we are looking for the LFB to sign, so we're waiting for...
And when is that day?
The MOU was agreed with LFB management last week. We're just waiting for agreement.
Okay, because I mean that's part of our assurance to be able to, it's a case of can you pick up the phones in time, and I think you've given us confidence you can. Have we got the number of vehicles? We have, but will they be fit and ready? So question about the AA. And have we got the staff to put on them? And part of that is the LFB. And then have we got the kit, PPE and other stuff? The things we constantly need to know. I think, Sheila, you were next, I think.
Yeah, thanks, Chair. It was just a point of clarification, I think, Kadir, just on the resilience changes to the CAD. I think it's fair to say that, that adds some resilience, but of course, until the new CAD is implemented, which is not due till next year, we still carry some risk with the existing CAD. So I just think just managing expectations around how far you've been able to take the current changes. So we still have some risk that we're sitting on. Is that fair?
Well, the CAD is 10 years old. Our computer-aided dispatch system is 10 years old. The software is 10 years old. Although we've upgraded the hardware, it's probably not in line with the most up-to-date and modern computer.
I think we should just remind people that we took a proactive decision to do this temporary bit of work before putting in the new CAD because of COVID. So it was an active decision.
Chair, in answer to Sheila's question, just to be direct, yes, the CAD continues to have some residual risks given its age and its life and its levels of currency. In answer to Karim's question, just to be really explicit, Karim, yes, I do believe we are prepared. Yes, I do believe we've got the resources, both people, infrastructure and vehicles and kit and are ready and resilient.
And let's go to Lorraine. Same issue. Was it about the money you're going to talk about, or?
Yes, I was just going to add to sort of some assurance on the PPE approach, because it was something that I was discussing with our North West London CFO. I think it's very clear that the systems are taking a much more proactive approach. We've already stood up in terms of tracking sort of the stock. So just to really give some reassurance that each of the systems, I think, will be tracking, will have early warning signs about any key items of stock coming below 21 days.
Right.
I'm advised that we've got about 100 days worth of stock right at this point, and clearly that is something that we'll be looking at with the Brexit sort of added challenge at the end of December.
Okay, that's helpful. Thank you very much. And Garrett, do you want to come in? I should explain to the public that I'm looking at the screen of board members and somehow they change where they're sitting without moving. So keeping an eye on them is quite difficult. Garrett.
So I just wanted to come back in just to slight clarification around the fire brigade situation. I think what Kadir is talking about is an ongoing relationship with the fire brigade that we are looking to agree, that we have not yet agreed, which would be to rotate, as it says, a number 50 to 100, 75 firefighters through our rotas on bank shifts on an ongoing basis, which would enable them to stay skilled up and stay trained and stay familiar with our equipment and so on. That has benefits for the LFB in terms of keeping their firefighters' skills, their urgent emergency care skills fresh, and it has benefits for us in terms of providing that future surge capacity. What's separate to that is if we go into a second COVID surge, and it happens very fast, do we have the ability to ring up the fire brigade and say, actually, can you lend us back the 300 to 400 firefighters that are already trained up, that have already done several months on our ambulances and so on? That facility still exists, and that's part of our surge escalation plan. Okay. But that would be, if and when we needed that, that would be a very specific conversation, either at my level or at Kadir's level, with the fire brigade, and obviously that would be subject to their operational demands and needs at the time. But we wouldn't anticipate that if we got into a second COVID surge of a similar scale to the first one, that we would have a materially different response from them.
Okay, thank you. That's helpful. Anybody else wanting to go? Mark, yes, please.
Kadir, you know that I'm anxious around A&E handovers for ambulances, particularly with winter coming, with A&Es being much smaller in space, with streaming making it much more difficult for the hospital scope, and every year we have problems with handovers. I think this could put a particularly large strain on our crews who are standing outside waiting to hand over and have a big impact on our ability to serve. And it's really out of our hands. It's up to hospitals to respond. And we have very small levers and they have little incentive to manage it.
Okay. I'm going to bring Fenella in here because I think she probably wants to come before I bring Kadir back. Fenella, is it the same point?
Yes, yeah. It is. Mark, thank you for that. And as you're aware, there's a lot of work going on across London. I think the work that we're doing with ensuring that patients get care in the right place and we don't default to the emergency department because no other pathways are available is going to make a difference. And the same day emergency care access is now being mobilised across the acute trusts to ensure patients who need diagnostics but don't need the skills of an emergency department will be able to be cared for in different places. That work's being done jointly internally between Kadir's team and the clinical directorate, and to support it and to make sure that we are aligned with the London region. I've set up an internal London Ambulance Service clinical advisory group so that the pathways are approved internally and fit for purpose for us as well. Okay, thank you. Kadir, did you need to come back or is that all right?
Only just summarising, I think in answer to your question, there's three parts, I think, Mark. There's one generally about working with collaboratively with our regional partners, both providers, commissioners and regulators, to make sure we've got a combined winter plan that understands the interdependencies and the interconnectedness. The second is, as Fenella's pointed to, establishing and enhancing the same-day emergency care arrangements and really exploiting those to reduce conveyances to hospitals. And the third is working with local departments, and where we've got particular challenges or historically issues, that's where we're focusing our effort.
Okay, thank you. So, I mean, what Mark raised is the plan needs to be winter, COVID and flu. And could we just talk a little bit about what confidence do we have that our flu vaccination programme is going to be widespread, swift and, timely this year? Is that a Fenella question?
I think if Fenella wants to do I'll do the operational bit.
Thank you. Got Fenella start, then Kadir.
So we have begun to take receipt of the flu vaccines now and started the rollout of the programme. We are linking it for frontline clinicians to their training session, which is mandated. And we have a very clear operational plan to deliver it. We have moved to an online system for people recording their vaccinations. So if someone has it through their GP or has the vaccine given in another environment, we will still know that they are safe. And our communications team have been supporting us with a huge amount of work to ensure people understand that this year in particular, we know from patients who have been unfortunate enough to be admitted to hospital with COVID in the first wave and had a second respiratory virus on top of it, their outcomes were sadly worse than those who were only fighting one illness.
Okay.
So we're pushing that clinical message to encourage uptake.
Thank you. Kadir?
Only just to reinforce the point that as part of EPCR rollout, we need to train circa 4,000 of our frontline crews by the end of this calendar year. While that training is taking place, they will also get their flu jab. And so what we're hoping to do is...
They probably need to have had their flu jab before the end of November, is that not right? Clinicians, Mark, Karen, Fenella. So are we having a target percentage completed by the end of October and the end of November?
Yes, so we've got a flu plan that is coming back to our daily leadership team meeting tomorrow, and we can, I think we can set out the targets by which we're looking to achieve, but we're aiming for a very, very, very high percentage of flu.
So I think the only challenge left from Karen's first question was really very good process. You've got daily meetings. Can we be assured that one is then thinking ahead when you begin to see a surge, one's activating early those extra staff you need, or the AA, or that who we haven't talked about? The AA is still coming, are they? For the Make Ready?
We still have the AA on site providing support.
So then we know we can pick up the phone, we know we've got the vehicles. You're telling me that you know they can be made ready.
Yes.
And you've got extra staff that you can get. You've got extra staff available anyway, going beyond. I'm now talking about delivery. And there are more you can get, and some of that will take a bit longer. And the flu plan is going to be really part of that. And the winter plan and the flu plan and COVID plan is all going to be one document.
Yes.
Yep.
And Mark has asked, Mark Spencer, our chair of Quality Committee, has asked for a separate session where we take Mark and colleagues through that winter plan in advance of the next whack.
I think that would be really helpful, and it might be helpful to share that, Mark, when you've got your report with all non-execs for that final assurance. Thank you. I think that's... Any more questions on that? No? I think it's been worth spending the time on it because it is really important, and when we're looking at what's coming, what I call down the M1, for a better way of describing it, as opposed to going up the M1 last time, we have reason to think we need to be prepared. So thank you. Any other questions to Kadir on the rest of his report? No? Okay, we'll move on then. Thank you, Kadir, and thank you, Fenella. Right, so that moves us to the integrated performance report, and we take that by director separately. So you've got an integrated report and then a specific report by each of the directors. So quality, clinical, and then the quality assurance committee. So starting with quality report, is that you, Tricia?
Yes, thank you, Chair. Just to take the paper as read, but I would want to note a few points, and it links to the conversations about our preparedness for COVID and how we monitor when we get peaks in demand. So as you can see on the IPR report, in relation to when we do have delays and when we have peaks, the work that we do, that we started in COVID, but we are now continuing that with daily reviews of the delays and the patients who go over their response times. So we have reviewed all the cases, certainly all patients who need emergency care, cardiac arrest, strokes, are conveyed in the right timeframes or have not seen any harm from those investigations. Where there is urgent care, clearly we have times when patients are waiting longer than we would wish. However, we don't have any evidence that that has impacted on harm it may, what we don't know is what the potential outcome is on their outcomes. So we monitor that daily. What we have seen over the last month or two is a peak in delays at our handover time. And for the public, that is when our staff change their shift. So they're they're finishing their shift and handing over to the next crew. And we have raised that, identified that, and Kadir has put in actions in place to make sure we do not see those delays at handover time. Good. And part of the information that Kadir gave you in terms of regular daily monitoring, looking at staffing, looking at incentives, looking at how we change the rota at those points in time will hopefully reduce that risk significantly. What we are seeing currently is a reduction in peaks of delays at handover time since August. So that work continues, and we will continue with that daily through COVID and ongoing. Also, just to note that we have now secured funding for the mental health response car, which, as you know, is benefiting our mental health patients significantly. And in the south, they have agreed to fund that till the end of the year. So we will continue working with our system partners to establish. And just to note the excellent work of the end of life team and all of the work that the quality team are doing in their various areas. Clearly, Garrett has pointed out the work we're doing about violence reduction, which is a real focus for the health and safety team at the moment. So that's happy to take questions.
Fine, thank you. Any questions for Tricia on that part of the report? Jane.
Thanks, Tricia. You mentioned in your report about complaints, and there's a fairly staggering number in there around conduct and behaviour complaints, accounting for 54% of those. And I was wondering, what do we do when we see those complaints and that they're about the behaviour of our people? What action do we take following that?
Okay, thank you, Jane. Just to say that when we look at these complaints, and it's about 50%, as you can see there, about a third of those are complaints where patients are saying they don't feel that the crew have acted they're not sort of acting as if it's an urgent situation. Now, that's what they're trained to do, is to calm patients down and not make it seem like it's urgent so that we don't upset patients. The other third is around basically complaints about not being conveyed to hospital and the sort of debate that goes on around that. And clearly, if they are not appropriate to take to hospital, we don't do that. The other third is around potentially abruptness of staff, not potentially communicating in the way that patients do. So for every single complaint, we feed that back to the line manager of the individual who has been reported from the patients. The line manager has that conversations with the individuals. However, what we do know is this is a trend in ambulances generally. It's not just London Ambulance Service. So this is why we've included it in our patient safety investigation process to look into why is this increasing. And it could be because we're now dealing with delays. Delays used to be our highest point of complaints, and we're not seeing as many normal times. And so we have put that into the patient safety investigation framework. We're working with our system partners and doing a piece of work around why is that becoming now one of the highest complaints that we've seen. And it may be related to stress levels. As we know, ambulance services have been under immense stress over the last year, and we think it may be related to that. So we're working to put a programme together to look into that more deeply. But just to assure you, when we do have complaints, individuals are told, and the response is taken from that individual back to the patient.
Thank you.
Thank you. Sheila, then Fergus.
Tricia, sorry, thanks. I just had a question on the body-worn video cameras. I mean, there's quite a good update in the integrated performance report, but I still don't get a sense of dates or timing by when you would have the service rolled out to everybody. Can you give a little bit of an update on that, please?
So just before we do that, for members of the public, we agreed at a board way day we had some extra capital that we could afford to give everybody, frontline staff, a body-worn camera, not just do the pilot. So it's the latter that Sheila refers to.
As we know, it's a trial funded currently by NHS-INE, and we are part of that trial. We are in a group of ambulance stations who are trialling the body-worn cameras, and we are also the lead evaluator for that trial. So clearly COVID did put a pause on that. what we have agreed now, our meeting is this week for the body-worn cameras. We have now got the procurement agreed for the cameras for the trial. We have also got UCL, University College London, who are our evaluators, agreeing where we pilot in sectors based on risk. And we anticipate our trial starting on the 1st of November and rolling out. Now, the trial from NHSE is said to be a year, but we don't believe we need to wait a year, nor would we want to. So we will trial it November, December, January. Clearly, that's over the winter months. And then we will review it then. And then we will take a view agreed by the board and others as to whether we then just roll it out across the organisation. And I think, the decision will probably be that we start to roll it out from February onwards across the whole organisation. But the trial will help us to understand how we implement that, any issues we have with downloads and using the cameras, training and education of staff. So 1st of November, the trial. February, we want to start rolling out across the organisation, but that will be based on the evaluation. So they're the timeframes currently.
I think it's fair to say that the non-execs had a different understanding of what we had agreed to do, which perhaps we could pick up outside of the meeting, if we could, Garrett. Okay.
So that's fine.
Yeah, thank you.
Please.
Right. Could I just have a question, if I may? When you're talking about the investigations into patient-facing staff, and the stage 1 ones were complete. Of the stage 2 ones, how many of there were 50? 5 of those were complete and 5 initiated. What about the others? What is worrying me is if we have another spike and we're still doing those.
So that's the RIDDOR reporting on the health and safety executive investigations.
Yeah.
So we have completed 15 now. They are very, very thorough investigations, as you would expect, because we are actually looking very comprehensively across whether or not staff had PPE, etc., who were they exposed to across time frames. So they do take quite a length of time to review. What we do clearly, though, is have the learning from those quickly, and we have fed that back in immediately back to areas where they have specific issues or where we see trust-wide learning. So we are learning as we go along in relation to these investigations. So we have currently completed 15 and we have another, we will anticipate finishing the final of the initial 57 by the end of middle of November.
Middle of November.
So,
okay.
But I can assure you, when we get learning, which we have, we feed that straight back.
And I'm more worried about the queue that will start coming if we get another spike, because it's inevitable.
Yeah.
Fergus, you wanted to come in.
I think the learning from these investigations will reduce the number that we have because the learning is about wearing PPE. The guidance has changed dramatically. We have now got more guidance. We know more about the disease, and we are monitoring compliance. So I anticipate we won't have as many.
Okay, thank you. Fergus?
Thank you, Chair. My question was in the same area, actually, around health, safety and security. And my first question was exactly the question you just put. I noticed that we are not looking at people who don't actually work for LAS, and yet it would seem to me that there are also lessons to be learned from those situations. I guess these are people working in Make Ready and in other ways. So my first question, apart from the one that you've just asked, Chair, is shouldn't we consider those situations? And my second was to do with a comment slightly cryptic, improving the return to work process to consider potential for staff to return while still contagious. I wasn't quite clear whether the improvement would be that they should not return while still contagious or that they should. And so I'm really not sure what's intended there.
Well, I think for the public, we do need to be clear. So,
yes.
Can you help us?
So clearly it is making sure that they do not return to work when they are still contagious. We found in 1 or 2 cases staff have been coming back after 2 or 3 days and it hasn't been monitored closely by line managers. So definitely not return to work while still contagious is what we aim to make sure doesn't happen. In terms of vehicle prep, we are clearly looking at corporate staff, and we are looking at areas other than direct operational teams. So, and we do pick up if there is a cluster, if there's any infections that we see in those areas, we will then look at all staff. So anybody in the area will be picked up and reviewed if we see there is a cluster, for example, fleet and logistics, or what you mentioned, vehicle prep. We will look at them. So
Okay,
we're not excluding them entirely.
That's helpful, thank you. Okay, if there are no more questions to Tricia, let us turn to Fenella. Your report, please.
Thank you, Chair. So the 2 points from the integrated performance report that I would just bring to attention are on page 4. At the bottom, you will see that the ambulance quality indicators have now been restarted after having been put on hold during the COVID peak 1. The dates are therefore very delayed, so we are just receiving the data through for December 2019 and January 2020. Obviously, from providing assurance around the quality of care and the safety that we're providing, such delayed data when it's coming from a national database provides us with a challenge, and therefore the clinical audit and research care bundle reports on a monthly basis, and in my report you will see the June stroke care bundle and the May ST elevation, so heart attack care bundle, both of which provide us with assurance around the quality of care on scene. It doesn't have the outcome data, which is what the AQI data will provide us, and they are working hard to catch up on that. With regards to the rest of my report, the areas I would just bring to the board's attention are we revised the major trauma decision tool during COVID to ensure that the most seriously injured patients were being taken to the major trauma centres. And based on that and a review of the work that's been in place since 2010, when major trauma centres were rolled out across London, we have now, with the support of all of the major trauma system and NHS England, been able to reissue a trauma decision tool, which enables us to take the most seriously injured patients directly to a major trauma centre, but not take patients who can adequately be looked after possibly in a more timely way at a local trauma unit. So that has been rolled out. The advanced paramedic practitioner I reported on last time was just in a recruitment phase, and I'm pleased to share that we have appointed 22 urgent care advanced paramedic practitioners and 8 critical care to increase the number that we have providing care across London. And the final point to just bring to attention is the infection prevention control. As everybody will have been very aware of, the amount of work from the infection prevention control team has been significant during COVID, working very closely with the health and safety team. We were asked to submit an assurance paper to NHS England to provide assurance around the infection prevention control measures that we were doing. That subsequently was shared with the CQC, and we had a telephone interview with the CQC and subsequently received a report which did provide assurance to the organisation and to the board that we were compliant in all areas.
Well done, thank you. Okay, any questions? Yes, Mark.
There's one question for that. Thank you for a nice report. I know that during the coronavirus, you set up a new pathway with UCL regarding stroke patients. I wonder if this June data included that pathway and if that's continuing to be effective.
So this was the pathway for North Central London, whereby a patient who is responded to by a frontline ambulance is video assessed if they don't meet the immediate criteria for conveyance to a hyper-acute stroke unit. That has continued and has been successful and we are now looking to roll out into Northeast London. The additional time on scene to get the right destination for the patient has increased by about between 8 and 10 minutes. We have been able to ensure that the right patients are being taken to the right place, and it has freed up enough capacity within the hyperacute stroke unit for us to now be able to take high risk transient ischemic attacks. So that's mini strokes there. So we're getting a better service for those patients who were previously taken to a local unit and then referred via outpatients. Northeast London are just working up their pathways to be able to implement that as well. As we move forward, it's really important that patients with that type of acute illness continue to get access at the best place for them and continue to feel confident about where we're taking them to.
That's a brilliant advance. I'm wondering where it's being evaluated, reported, and the plans to roll out across the rest of the capital. Indeed, nationally.
So it's being, at the moment, it's being monitored as it was a COVID pathway through the London CAG, and an evaluation is ongoing with every case being reviewed.
Fenella, Clinical Advisory Group, London Clinical Advisory Group was CAG.
Sorry, yes, the London Clinical Advisory Group. Apologies.
Yeah, good. Rommel.
Thank you, Chair. Just a question. It might be more for Kadir. I'm not sure. I was looking at the integrated performance report, and I was just picking up the 111 IUC performance, and I noted a shortage of CAS clinicians, and additional, I think, a reference to additional external. Just in the context of the national move to think 111 first, what can and what are we doing about CAS clinicians?
So, well, let me start and just check in with Fenella on that too. I think that the reality is the service specifications and the model of care that we've got in integrated urgent care in South East London and North East London has evolved over the last couple of years. And what we found during the peak of COVID was trying to provide all of the kind of clinical assessment service within integrated urgent care in North East and South East was not the best model of care. So what we've been doing, and what everybody's recognised is it seems to be better practice, is much greater integrated relationships with downstream primary care and community care providers in order to maximise the clinical capacity available in that geography to manage some of the clinical aspects of the patients and callers coming through 111. And I think that's the model that we're really looking to continue to develop and pursue in South East London and North East London and beyond, in terms of any opportunities we have for working across London. The measures in the clinical KPIs that were originally developed as part of the North East London and South East London specifications need to be, well, there's already a regional piece of work to revise them and think about those clinical indicators at a system level as opposed to within LAS's contract as a provider, because actually our clinical assessment and the times and types of responses to clinical care needs to be owned more broadly across the system as opposed to just within the LAS, and that's the conversation now currently taking place. I'll just give you an example of that. During COVID, not only have we had to change, but primary care has had to change as to how it delivers its services. And it's clear, you know, we've been talking about telemedicine, haven't we, for a long time. The move to kind of video consultations has grown exponentially. And I think there's much more opportunity for us to think about how we work together across IUC, 111 IUC and primary care in North East and South East, and that's the work that we need to do. I don't think us growing our clinical workforce in North East London integrated urgent care service is the answer. The answer is to work across the system to maximise the resource already there.
Thank you. I'm going to bring Fenella in.
So just very briefly, Rommel, just another innovative piece of work that we are rolling out at the moment, it started last week, is in North East London, where we are the 111 and 999 provider based on the learning that we had from Perfect Day last September was to set up a system of, on that day we did call a colleague if you weren't sure which pathway to access. We're now working with both BHRUT and the Barts Health system on a process whereby the 111 and 999 clinical assessment services, so the emergency and the urgent clinical assessment services, can access directly an emergency medicine consultant or a frailty consultant and be able to try to book a patient in at a time that is suitable for their clinical need, rather than conveying automatically to the emergency department and then potentially being admitted when they have an urgent problem as opposed to a life-threatening problem.
That's really helpful. Thank you very much, Fenella. Did anybody else want to come in before we move on? I just think there is one thing that it would be interesting just to have a very brief update on, which is the first cohort of 72 assistant ambulance practitioners. This is an important development. So would somebody just like to give us 2 sentences on that and how you see them fitting in?
I was planning on picking it up briefly under what would have been Ali's item.
Okay, perfectly. Do it there. That's fine. Thank you. So thank you to Fenella and Tricia. That brings us to Mark then for the subcommittee of the board, the assurance on quality report from the quality committee. Mark.
And I'll just take the report as read. Happy to take any questions. There are 2 things to escalate. One was a terms of reference change in that the committee the authority of NEDs in position. We don't feel that's necessary, so recommend a change to that. That clearly needs the board's approval. And secondly, a review of the BAF, which I think we'll pick up in the BAF report later in the committee.
Okay, so let's just take the terms of reference for now. Thank you, Mark. Are people content with the revised terms of reference? Garrett, have you had a chance to look at them? Yep. And I take it that Tricia and Fenella, you approve them or they wouldn't be here. Yep. Okay, so yes. Garrett, did you say you were happy? Yep. Okay, no dissenters, then we can approve those. Thank you. And we will pick up the 111 under the BAF conversation. Thank you very much. Okay, moving on then to 8.2, the People and Culture report, which I think, Garrett, you're taking, and are you bringing in Jason for this?
I probably will, unless it gets really difficult. I won't bring in Jason to this, but
okay.
We have quite a lot of the content is obviously covered in the item that we have.
Yes.
Further on the agenda, specifically on Black Lives Matter, to which I will bring Jason in. But aside, so I wasn't going to talk about that, but aside from that, just 2 or 3 things that I think are worth pulling out, and Jane may wish to add anything. Just first of all, the good progress that's been made on COVID-related staff risk assessments, where now we have, it says there 98% of all our BME staff, 96% of all our vulnerable staff, and actually 97% now of all staff have had COVID risk assessments completed, which is really good progress. A huge amount of work gone on, not only with people and culture, but actually within the operation teams and the directorates to complete that work with managers. You mentioned just slightly earlier, Chair, about the ambulance practitioner appointments. So yeah, really good take up from that. A huge amount of work from operations and from the recruitment team, and now training in terms of getting that the training up and running, which is going to take place at an interim training centre down in Canary Wharf that we're setting up, obviously on the back of some of the changes that we've had to implement through COVID. 358 external, 357 internal applications for the 240 roles. That's really good news. It's correct me if I'm wrong, but I believe it's a 12-week training program. So we will have those staff coming on stream over the winter, which is when we need them. And also, although we've been somewhat limited in our international paramedic recruitment, we have continued to be able to recruit to international paramedics. We had 37, I believe, started training recently, including 14 from Namibia, 11 from Namibia, and two from Australia, and 1 from New Zealand on top of that. So there is still a supply there. Our paramedic establishment still looks healthy. You'll see the details in the integrated performance report. I think overall, we've got a 4.6% in-ops vacancy, less if you include the staff in training. But there is still work to do to close the anticipated gap through the rest of the year, as we expect through sort of natural wastage and roll-off and the potential demands that the partnership working with PCNs will put on our paramedic placement. There's still a gap to close. We think it's still around potentially up 240, 250 by the end of March. That we're looking to close. So that's work in progress in terms of the workforce planning, and we will bring a paper to the People and Culture Committee to cover that in due course. Kadir, shout if I've left anything out there. Finally, just wanted to mention staff survey, which opened, the annual NHS staff survey opened at the beginning of last week. The data we had at the end of last week says that 13.7% of our staff have now already completed that, which is a good start. We will be pressing on with that. You'll see that we had a record response last year at 71.5%. We're aiming to beat that again this year to make sure that we get a good and full reflection of what staff have felt like working in the organisation over the last year. And I think it'll be really interesting to find out, given the challenges we face. I think that's what I was going to highlight, but obviously in conjunction with Jane and
yeah. Okay. Should we bring Jane in? Do you want to add to that, Jane, from non-exec lead and wellbeing lead?
Yeah, I think just to clarify, the assistant ambulance practitioners, we're looking actually now to recruit 184 rather than 240, and we expect them to finish their training and be operational in February, the first cohort, and then subsequent to that in April. So that's in train and is now happening. I spent some time with Garrett and Kadir last week looking at the workforce projections of numbers, and we're clearer on that now, and Kadir's gone away to do a little bit more work, which myself, Mark and Karen will have a look at on October the 12th when we convene again to meet. I just wanted to pick up a couple of points, Garrett. It mentions here that the workforce race equality strategy for London, the draft has been produced. I think it would be really good if we could see that draft, because I haven't had sight of it at all.
Yeah, I don't know whether we've seen a draft of the full document. We have seen a draft of the case study that is the London Ambulance Service,
okay,
which we've inputted, but we haven't seen the whole document yet, I believe.
Okay.
Might be worth chasing that up. Thank you.
I think it would be really helpful to have sight of it. And then my second point was the How You Doing survey. Again, I haven't seen any infographics, so it would be really helpful to see that, the second time around now, whether the themes are still the same as the first time around, and what actions that we've been taking in the meantime, and whether those actions are delivering on how our people are feeling. And how they're doing. So it would be great if we could see a sight of that as well.
Yeah, I'll pick that up.
Thank you very much. Okay, if there's nothing else, thank you both. I'm going to move us on to finance and audit reports. So Fergus, I don't know which order we're quite doing this in. I've got your...
Chair, shall I start with
Yes, it would be better. I think it's slightly in the wrong order here. Sorry, yes, do.
Yes,
and then we'll go to Fergus for finance investment and then Rommel for audit assurance. Okay, Lorraine.
Thank you. So the report I'll take as read, and it's based on the month 4 data that's in the integrated performance report. I think I'd just like to flag a couple of things that have developed since I wrote the report. The month 4 position, we broke even. We continued under the existing arrangements, financial arrangements, to ensure break even for all organisations. That will come to an end at the end of September, and we have on the agenda a specific paper to look at the plan for the second half, so I won't dwell on that. I think the things to note, we had 33 or 34 million of COVID-related expenditure cumulatively, and to date we have been funded for all of our claims. The month 4 retrospective top-up was actually slightly higher than the COVID claims, and that was due to the recognition of a cost, the write-off of an asset in relation to the replacement of our dispatch system. And that is part of the Digital 999 programme that was budgeted for. So that is really just for those that are interested. We are still awaiting the month 4 retrospective funding. And I think it's fair to say that sort of the national team is looking sort of at doing an analytical review just to ensure that all expenditure as we move into the sort of next half of the year is reasonable. But we expect that to be funded as part of the month 5 review. The only other thing I wanted to focus on was that we have a very strong cash position. And the final bit is that we have been very successful, as we've reported before, in gaining capital investment, which is a real opportunity for investing to improve both resilience and modernisation of our estate. And our focus has been on approving, and we've got a sort of a welcome a number of business cases coming through the pipeline. So the really key thing is that we spend that capital. I'm happy to take questions.
Okay, thank you. I think what I'm going to do is ask Fergus and then Ron to do their reports, and we'll pick up questions together, if that's all right, Lorraine. Because we also have more papers in Part B, business cases that are of confidential nature and more finance, don't we? So Fergus and then Rommel.
Thank you, Chair. We have an item later in the agenda on the financial plan and the capital expenditure programme, so I won't refer to what the FIC said about those until we come to that item. Likewise, we recommend approval of the business cases, which we will deal with. I think it's worth emphasising that we had a very valuable presentation from Lorraine about work that's been doing to systematically put in place a new cost improvement program, building on work that's already been done, but looking forward in the context of our strategic plan. And I think the committee was very strongly in favour of moving that forward as quickly as possible. One other aspect I would mention is the importance of a 3 to 5 year plan in which to situate both the cost improvement plans and also the investment plans that I know are being worked on. And finally, to underline the issue around estate planning, 27 locations are no longer being used as active ambulance stations, and the committee was quite keen to see a plan to deal with the cost of continuing to support those stations and indeed deal with their ultimate future.
Yeah, thank you very much. Let's do Rommel and then pick up questions for all three. Rommel, for the audit committee.
Thank you, Chair. Just 3 or 4 points to draw out. It's all in the report, but I'll just draw them out to reinforce some things that I think are of note. Audit committee took a lessons learned review on the immunisation out of hours issue, and one particular facet of that, which is in the report, was on strengthening procurement, so particularly around a no purchase order, no contract, no pay arrangement. And actually the threshold has been reduced to just over 50k. So it may seem where it's a belt and braces approach, but I think that's required until we establish more of an embedded control culture. As part of that, we also looked at tightening up the single tender waiver process, which has been an ongoing issue for the organisation and for audit committee. So just to draw out that particular point. And then secondly, going to Lorraine's earlier update and the business at FIC, we do want to have an assurance review, and Lorraine is talking to our internal auditors about a benefit realization and capital control audit later this year. So that's something that we'll pick up at audit committee and then report back to board. And the last item, just to highlight, is that we took a very good piece of work on strategic risks. And I think you'll see that in the BAF. We made a recommendation on improving how we look at our risk appetite and trending that information. But secondly, also that suggestion that Garrett, with some of the exec, hold audit and risk clinics, which would be useful to do as another measure to improve disciplines around our audit and risk action points. And then a wider piece of work that Sima and others will be taking forward, which is looking at our assurance framework, which is something that other organizations do apart from the NHS. So that'll be something that'll come back, which brings more alignment and strengthening of our strategic and operational risks. And then something I wanted to introduce, which is a technique I've used in other organizations, as part of the year-end attestation process, this is think of the next year-end, how the directors might be qualifying, if you like, to the audit committee, their attestation on their internal control environment. I'll stop there.
Thank you. If there aren't any questions on those three, quite a lot gets picked up later. Should we move on to the assurance around logistics and infrastructure and take the D999 programme assurance group together? Is that all right? Are people content to do that? Note those reports. Thank you. Okay, so Sheila.
Thanks, Chair. So actually a lot has been said already because the Logistics and Infrastructure Committee reviewed some of the business cases. I think there's a recurring theme emerging around the level of rigour in terms of benefits realisation, benefit to the strategic ambitions we have across the trust. So one of the things that LIC recommended in terms of further assurance would be to make sure that as we bring the business cases forward, we have put some more rigour around developing and drawing out those benefits, particularly around the options evaluated, why certain options were ruled out, and the efficiencies that we're expecting. So I'm pleased to say that a lot of those points have been taken on board and followed through to the Finance and Investment Committee, which is really good. The second point I just draw out is that we also spent some time reviewing the resilience, the IM&T resilience and cyber remediation programme, and we're pleased to see the progress and evidence of good progress being made. We've already heard about some of the interventions around the current computer-aided dispatch system, but equally we're pleased to note further investment in some of the cyber remediation and controls that are required. We also heard at a high level just an update on some of the plans to invest in the capabilities and skills within IM&T, which we welcome. But we did stress the need to also focus on culture and leadership development with a view to ensuring or providing further assurance that as we move forward, we have an IM&T capability that is able to address and support and enable the digital and technology ambitions we have across the Trust. So those are the points on the LIC. I might just turn quickly to the update on the EPCR and CAD programme. That's the D999 programme as we describe it. So you've already heard from Kadir on the progress that's been made on the EPCR rollout, or certainly the pilot rollout. Both programmes at the moment, or at the time of writing the report, we're tracking to amber status. There are a couple of challenges that need to be addressed around some technical challenges and some resource constraints. The biggest risk that we're tracking is obviously the impact of a COVID second spike, and that may well impact our ability to train the frontline teams. So that's being monitored closely and carefully. And the other risk we're tracking is around, as we get into running the workshops to understand the end-to-end processes associated with the new CAD replacement, that may well throw up some additional challenges around further technical development that's required. So we need to just keep a very close eye on that. And finally, just to mention that, well, two final points. One is that we welcomed a couple of our frontline paramedics to join our meeting to talk to us about their experience with the new patient record system. I'm really pleased to hear directly from them, and the feedback was very positive, and it supports the further evidence we received around the surveys we're doing to understand how the pilots are being received by our frontline crews. Any adjustments and changes are being fed into the process so that those adjustments and changes are being addressed in good time for the full rollout. And finally, we received a report from PwC, who we've invited to run a number of reviews, again, to provide additional assurance around the quality of the programme. This first review was focused on governance and project controls, and we're pleased to note that the first review actually provided very positive feedback that the programme is progressing well and that the governance arrangements that are in place are very good practice. That being said, the report did highlight a need to put greater focus on linking the EPCR and CAD programme to our wider strategic activities to make sure that we had very robust tracking for benefits realisation and to pay more attention to our change management, particularly as we roll out the EPCR in earnest.
That's really helpful, Sheila. Thank you. So are there any questions for Sheila on the first paper on logistics and infrastructure? And then we'll take the D99 programme second. We've got the business cases coming where we'll talk more in part B. Anything? So we'll note that. And on the 999, that's a very helpful update and assurance with some action. Any comments on that? No, so we take that as read. Thank you very much. So that takes us to item 9, which is month 4, which I think we've done, haven't we? But the financial plan going forward for 2021 and capital expenditure programme. Lorraine, over to you.
Thank you. Thank you, Chairman. So the paper before the board is requesting approval for the plan for the remainder of 2021 in terms of revenue and capital. It is an unusual circumstance, but not the first time that I've requested approval of a plan in the absence of the final agreement on the financial envelope. But it is important that we have a clear plan that can assure and underpin the performance delivery that we've heard about in the Chief Operating Officer's report. So the first thing I'd just like to flag, we are in a process within North West London ICS, which will be agreeing our envelope as part of a system envelope by the beginning of October, and that process is currently working its way through. But I think I can say that we've had very constructive discussions to date with the North West London Healthcare Partnership. The things just to flag the plan by agreement with North West London is that we are proposing to spend in line with our month 4 forecast as it currently stands. That would provide a resource envelope of 527 million. And within that, I've set out in the paper that will provide the national standards for performance on the call taking and the ambulance responses, given the expected level of demand. It also factors in the possibility of another COVID spike. It's difficult to model exactly what that will look like. So for the purposes of this plan, we've assumed it's equivalent to the original spike in March. We've also sort of set out, and this just underpins the assurances I think that the board were looking for in the COOS report, sets out what this will actually deliver in terms of patient-facing vehicle hours on a daily basis, and I think will give some confidence that we have the resource in place based on this plan. The final part is that, as I mentioned, as alluded to, we have a significant increase in our capital investment plan, and that is nearly double the investments that we've had in the past. Now, whilst we haven't received formal agreement to the phase 2 COVID spend, the North West London Healthcare Partnership is content for us to proceed on this basis, and just reminding the board that our capital resource limit forms part of the system's capital resource limit. And then finally, we have completed a section on the sort of risk assessment. So being sort of very, very clear that we are mobilising an efficiency programme, which Fergus referred to, and that we will be working that through in the second half of the year. The main focus is really on 21-22 now, to ensure that we move into next year capitalising on the investments, the benefits that we are going to see through that in capital investment. So I will stop there and take questions.
Fine, thank you very much. I know there have been a lot of questions outside of the meeting, but points. Fergus.
Yeah, first of all, to say that we discussed this forecast quite thoroughly in the Finance and Investment Committee, and were very encouraged by the work that Lorraine and her team have been doing to put across the reality of our own situation, what we're aiming to do, and the cost of our COVID response. In terms of the financial plan that we're asked to approve, was supportive of approval, but subject to some caveats. The first, of course, is to spell out exactly what will and will not be covered in terms of our capacity to respond to a surge in activity. In the first 6 months, we were working in an environment where we were, in effect, guaranteed to break even. In the second 6 months, we're working in a context where a block amount of money will be agreed. So it's very important in our conclusion of our arrangement with the commissioners, to spell out what we can and cannot deliver within that envelope. And likewise, it's important to spell out, when the final figure is agreed, what we can and cannot do for that figure. Likewise, Lorraine has talked about the risks, and it's very difficult for this committee to judge, but there may well still be an element of risk around the capital funding that's available, although, as Lorraine has said, we have been encouraged to press ahead with that limit. I think the other point I'd make comes down to CIP. The cost improvement programme activity was in effect suspended during the COVID pressures. A great deal of work has now been done to identify and reconfirm and revalidate the opportunities. I know Lorraine has talked in terms of focusing on next year, but it does seem to me, and I think to the committee, that it's important to crystallise and to move forward with activities in the current year, because they are likely to be necessary in order to bridge any gap between what is agreed with commissioners and the sums of money we need to deliver the service we want to deliver.
May I just come back on that point?
Yes, do.
Apologies, because I think I was slightly there is no intention to wait until next year. I think the recognition is that we're in a position now where there are a range of very significant sort of modernisation opportunities, but at the same time, we are standing up and recognising those opportunities that can be delivered within our current sort of operating model and estate. And I think what is really important is that the efficiency programme is not going to be delivered in the way in which we've done it in the past, with just what we sort of in the technical term use salami slicing, and just taking a rather short-term tactical approach. This is the moment when we have the investment to drive, I think, a really strategic programme which will give us the modernisation, the technological improvements and the efficiency delivery. So I just wanted the board to be very, very clear that we are not waiting until next year, but that we are just recognising that there are some different phases, but we will be mobilising the cost improvement to impact from the end of the next month.
Can I just come back at the end of the next month, meaning at the end of October?
October, correct.
So we only have 6 months from today, from the beginning of September. So we will have 5 months, won't we, max, to deliver the cost improvement that's required. You know, are we convinced that we can be assured we can do that?
Well, I think based on our current, well, I think the assurance is that the North West London have supported our submission for the revenue envelope in line with our month 4 forecast, and therefore it is important to start mobilising the CIP, because the recurrent impact we want to retain. But I don't
agree with you. I just hope we had started now.
I will take that challenge then. We'll take that forward.
Okay, Fergus.
If I could add, it seems to me that on the numbers, it is important that there is a contribution from CIP to the financial picture this year. And I think it's fair to say, Chair, and I'm pretty sure Lorraine would agree, that at our next meeting of the Finance and Investment Committee, we will be looking at a concrete target and plan that will deliver. I'm not sure at this point how much, but certainly something will be required in the current year.
Okay. I think Kadir wants to add into this one. Kadir?
Thank you, Chair. Just in some further assurance, Lorraine and I have started those discussions about this year. Only this morning we were speaking to people and culture colleagues to get a meeting into place to look at how we can generate the savings or the SIPs that we require for the remainder of this financial year to be able to manage and mitigate any risks to the financial position. So, you know, as the director with the largest workforce and probably and the majority of costs, there's a commitment from
the burden is heavy on your shoulders. Okay, Amit.
Chair, I think echoing one of the points that Fergus made, I think that we discussed this in detail at the FIC meeting, and we're clear about this desire to make sure that we're writing to the commissioners to say what is covered by this arrangement and not. We talk about the Think 111 additional activity that may come this way that's not currently within the agreed funding envelope. I'm just wondering, are we clear on how we differentiate about additional activity related to Think 111 versus normal phone calls that we get into 111, COVID, flu, etc.? Do we understand what we'd be teasing apart to say this is additional Think 111?
Good question.
Lorraine, shall I have a go at that? So I think we have to take what we take up to the 6-month period, but from this point to the end of the year, we need to try to do our best to differentiate between what we would normally expect as activity, what's been COVID related, and now what will be in addition to the COVID related activity from Think 111, because we've already seen, if I'm honest, this year between 50 and 100% increases in 111 activity that have been recognised and that have to largely been funded. But there's an additional element which we now need to think about how we're going to capture. There are national funds being made available for that additional activity. Whether they reconcile and meet the total costs
is another way of looking at that to say, are we assured that our modelling processes are adequate? And outside of this meeting, do we need to come back and say, is there anything we need to do to strengthen those? Because we are facing challenges that we have not seen before.
You're right, Chair, but I think that it's not just within the organisation, it's within the system.
I get that. Okay, thank you. So are there any more questions, or should we go back then, Fergus, to your bits of assurance that we didn't cover off? Are they for here?
Well, Chair, the aspects that I think that I said earlier we needed to cover off at this point related to approving the financial plan and the capital plan. So I think we have discussed those aspects and the caveats that we talked about. I think we have now discussed those.
So are we saying that subject to those caveats, we are approving this business plan and capital plan?
That was certainly what the Financial Investment Committee was proposing to this board, yes.
Okay, are people clear on the caveats? Or does anybody need a... We're clear? Okay, Lorraine, is that all right? Are we sufficiently... I know we're going to pick up more, but that allows you to move forward and allows you to spend the capital because, you know, we are cash risked because we're not spending the capital at the moment. We need to get on with it, don't we? Yep.
Yes.
Okay, Kadir, are you content? Garrett? Yeah? Okay, thank you. Tricia, Fenella, the board members? Yep, okay, thank you. Then they're both approved subject to the caveats discussed. Thank you, that's really helpful and very important. Let us move then to the business plan, another important document. And who is taking us through the business plan?
Thank you,
Ross,
Chair.
you're here. Hello, Ross. Thank you.
I won't go through the detail of the document. I'll take it as read. It really sets out the priorities for the next 6 months across the organisation, using 6 strategic themes of cultural change, health, safety and wellbeing, back to basics, enhancing patient experience, operational modernisation and corporate modernisation. We've touched on a lot of the topics in the meeting earlier today already, and this consolidates what we're doing in the next 6 months.
Okay, so sorry, can I just say, to be clear, the 6 strategic themes will be the 6 corporate objectives. Yes? So should we just pause there? I think everybody will be pleased to see culture right at the top, cultural change. Is the board, content that these are the right strategic themes? Yeah, I'm getting nods. Yep. Good. Okay, sorry, Ross, can continue.
No, thank you, Chair. Just to add that the work that we are now focused on is building on this to look at the plan for next year and beyond. So we will continue with these themes and we'll be working alongside the board over the next couple of months to develop directorate level plans for the next financial year and the next couple of years beyond that as well, actually. So this sets out the rest of this year and gives us a direction to build on in the future. So I'll leave it there and leave it for any questions or comments.
Okay, thank you. So are there any comments under cultural change that we're not picking up anywhere else? Fergus, are you trying to say something or you are? Okay.
Yes, Chair. I just wanted to add that it does seem to me that the document aligns with our original strategy, with what we've learned in COVID and what has come out of discussion with directors.
Yes.
I would make the point, however, that it's a plan that has very few figures in it.
Yes.
And I think it's described as a business plan, but we don't know the cost of it, and we have to make assumptions about the funding of it. And it seems to me that it's really quite important to move quickly to a point where we can put some numbers on the costs of these initiatives and on the funding challenge that they represent. I have a specific question about one of the segments, but I'll come to that as you work your way through the various goals.
Yes, I was going to go through goals. I think we do have to recognise that this has been a particularly difficult year to get any numbers for anything, given that we didn't have the the total revenue agreed, but it is a fair challenge. So on cultural change, does anybody want to add anything to that? Yes, Lorraine, and then Jane.
I just really wanted to finish to come back on Fergus's. I mean that it is unusual, nationally. We've got the activity and workforce plans have already been submitted, and the financial plans are now coming through at the beginning of this week. So we're not out of step with the overall plan. But that would be the intention, is that we now would pull together and triangulate all of those plans. And as I say, we need to complete the discussions with the commissioners, and that will be finished by the end of next week. And then we would be in a position to drop in the remaining elements that you'd expect to see in the plans, and if you've seen versions of our previous business plans.
Thank you. So let's then, Jane, you wanted to come in, didn't you?
Yeah, this is a bit more about the how, but will we as the board be engaged around the cultural assessment in terms of what that is, how it's going to be done, and what the timescale is for doing that? I can see that it says December 2020, which actually doesn't give us long, and I'm just interested, what the engagement process with the board will be around that.
I think Jane can answer that. I think the short answer to that is yes. I think that depends on our capacity to do that over the next 3 months. So I think this plan was written a number of weeks ago. Obviously, you'll be aware of developments, and we need to make some decisions around what capacity we've got. So to some extent, we'll need to look at that, but obviously in conjunction with yourselves as
yeah. I mean, a suggestion that came up yesterday was that we have a board development session on culture and equality and diversity, and thinking that through and having representations from people who are going to use, just thinking more about it, Garrett, to get everybody in this aligned. Is that a good thing to do? I think we've got one at the end of October which we could use.
I think that would be helpful.
Okay, thank you. Right, let's, did I think Sheila?
Yeah, sorry, Chair. Just on the workplace experience deliverables, the first one, improvements in 2019-20 staff survey scores across all workplace experience metrics. I don't really understand how that would be measured, and are we setting targets across all those metrics?
So the intent was across the board for them all to improve, and not all survey metrics overall. So there's not a specific target on any of the individual ones, but what we're seeking for is across that subset of the staff survey for there to be a continual improvement.
So I think we've got so far to travel. We might want to think about pulling some out, which we specifically put targets to, looking at the different areas, which I appreciate are different. But perhaps we can pick that up and think of it for our development session. Garrett?
Yeah, and Heather, yeah, I would agree with that. That's something I'm looking at in the development of the 18-month people plan, which again, Jane has been involved in, although it's not yet in a format that we would be comfortable bringing it to either the People of Culture Committee or the board.
Okay,
yes.
Thanks. So we will pick that up, Jane. Thank you. Health and safety and have I jumped? No, health and safety and well-being. So I'm glad to see in that one we appear to be rolling out the body-worn cameras. I'm not convinced we are. Sheila?
That was exactly my point, Chair. I don't know if this is a 6-month plan, how we can actually, be confident that we're going to achieve that outcome. Doesn't work for me.
Well, I think
based on the earlier discussions, we need to kind of come back to the board with a kind of clear view on exactly how that looks.
Yeah. I think that'd be helpful, Ross, because perhaps it's maybe in the pilot or something we're talking about, but I just don't think we could. I don't know how.
I think what we said at the development session was, we are part of the pilot, but we want to bring it forward because we know it works, and staff would really appreciate it, but we do need to take it outside. Kadir, do you need to add to that?
Just to say, there is a national pilot, but the board has been really clear around we've identified resources to roll this out this year. So I think the executive need to go back and come back to you with a plan that assures you that we will be able to do that. And if not, why not?
Okay, thank you. Right, anything else on the health and safety? Nope, then I'm moving on to enhancing patient experience. This is really important, links to the clinical strategy.
Sorry, Chair, on those back to basics, number 4.
Oh, yes, sorry, I missed it.
It's a
You had
very
missed
strong
one. Back to basics.
programme.
Sorry.
My only hesitation is in using the term.
You're cutting out, Fergus. Whilst Fergus is trying to get back on, I know that staff have fed back they don't like the term back to basics because they've used it before, and you had a better term, Ross, which I've forgotten what it was.
As have I, actually, Chair. I think it was about the foundations, but we need to make sure that's a term that is appropriate.
Getting the foundations right or something, I think you said. Fergus, where have you gone on my screen? It's gone. Okay, well, we'll move on and come back to it. Enhancing patient experience. Any questions on that? This is really important because it's what we're all about. Karen, were you about to comment?
Yeah, sorry. Just I think the meat of it is good. I just think probably experience and outcomes, or experience and care.
Outcomes, because we know from our staff they don't know what happens to the patient, and obviously if we're doing new treatments we need to know that the outcome is good. So I do think that's absolutely spot on. Patient, yeah, so clinical outcomes. Ross, please. Yep. Anything else? Oh, Sheila?
Sorry, just on the hear and treat rate increase, are we going to set an expected percentage increase within the remainder of this fiscal year?
We should do. Where, Garrett, what's your view on that?
Increase the hear and treat, we should do, but I don't believe we've set numbers yet specifically.
So I think what we're really hearing from all of the sectors, we need to put some measurable, these are our strategic themes. If they're objectives, they need to be measurable. So how can we, set a number and say, can we achieve it? And commissioners have got a view. Amit, sorry, I'll come back to you, Garrett. Amit?
I think linked to that, it's also how, not just what are the measurable targets, but where will we as a board get sight of progress against these? So it would be useful just to understand how will we track and know whether or not we're delivering against, what is quite a wide range of.
And I would have thought through the quality subcommittee with an assurance report from Mark as its chair. Is that in line with your expectations, Garrett?
The point I was going to make, Chair, was that I think you need to moderate your expectations in the very short term, shall I say? Let's the fact that we're producing a business plan in a post-COVID world for a financial year that tomorrow is half done. I think what we've got here is a set of 6 strategic objectives for the board going forward, which is a very big step forward that I think we're all agreed on. And we've talked, and I know you and Amit and Ross and I have talked about the need to be clear on 6-month, 18-month, and then longer-term objectives.
Yeah.
And I think what you're highlighting is that we haven't nailed down all the 6-month objectives yet, but at the same time we've only nailed down the funding.
Yeah. I think we could.
So it's really a matter of being able to bring something to the board now to be approved based on what we know.
I think 6 months might be difficult, but one could certainly say, a year, 18 months, what it would be. Because these are the objectives we're going to stick with for the next 2 to 3 years. So some of those will be easier to do than others, but we should, like the staff survey ones, should be easier to set a percentage by areas. Hear and treat might depend on other people in the system and see and treat. Fergus, you're back. We'll just carry on with the one we're on and we'll go back to where you were, if that's all right. Thank you. That's the vagaries of working in this way. So Sheila?
Sorry, Chair, just a point of clarification then on that. Are we going to then see an update on these objectives or deliverables? Are we going to receive an update on that? Because at the moment there's quite a lot in here, and I would agree with you, Gareth. I think we need to sort of focus on what are the things we're going to do in the next 12 months and then what comes after that. This just looks like it's a long and very ambitious list.
So the plan, I think, Ross and Garrett helped me, is to now turn this into directorate plans, which would have some hard numbers attached to them.
Yeah. So this was aimed as a document for the next 6 months, and mainly was around work that was underway towards delivering these objectives, but with a frame of the strategic themes that will carry forward for the next 18, 24, 36 months. So what we need to do now is build the more detailed plans, but plans that are in effect going to be from April onwards.
Okay.
I think if we were to come back to the board with kind of metricated targets at the next formal board meeting, there's only going to be 3 months of the year left to run. So I think that's about how we turn this into something effective for kind of the next financial year to really build on and get some content underneath that's got directorate ownership, as the chair describes, and really builds in a much richer level of detail at a lower level rather than being a purely executive level document like this one.
So Jill Anderson, for the Public, our Associate Non-Exec Director, who couldn't be here today, has asked, have we linked this to risks, which I think is a very good point, and what is critical, and is it the critical ones that need some targets, if you like, setting parameters for in-year versus going forward, and the business of how do we track progress would need to be sorted out.
Okay, thank you.
But I think this is a big step forward, I have to say, from what we have seen before. Do other people agree? Getting nods. It's just, as usual, more work in progress. We have to get on with it and get it socialised, for want of a better phrase, with our staff and with the divisions coming up with theirs. And perhaps we could urge the exec with Garrett to go back and say, where can we this year put some targets in that will be measurable for the rest of this year versus what we will start doing but see the benefit from in next financial year and the one after. Does that make sense?
Yeah, very good.
Okay, Sheila?
Sorry, I don't know if Fergus wants to come in, but I would have probably made a similar point to the one he was going to make on the back to basics. I think it's too narrow.
Right.
And if this is meant to be an enduring plan,
yep.
We need to be sort of talking about, where are we investing in new digital capabilities,
yep.
not just, fixing the basics, which is how I read this.
So,
gap here.
Just, Fergus, what you might have missed was the staff don't like the term back to basics, and it's something like getting the fundamentals right because they've had back to basics before. So Sheila's point, Garrett wants to come in, but was that your point too, too narrowly focused?
My point was, my point is more that the back to basics, I think, is perceived to be short-term only objective rather than the other 5, which are very much short, medium and long-term. And I think what Sheila's referring to, I think, is covered in the various information in the 3, the latter 3, the operational modernisation, the corporate modernisation, and the people modernisation. So I think there is a lot more in terms of digital transformation and so on in the ongoing.
In the interest of time, can I ask people to go back and look at the points Sheila's making, see if they come up later, and if not, we can correct that. But I think it's really a plan responding to non-execs consistently saying, have we got the bandwidth and have we got the basics right? And it's really this year thing to sort out and then going on to the wider ones. So I think it was in direct response. Fergus, was your point similar? I do need to move us on a bit. We're getting a bit behind schedule. You've frozen again. Right, I'm going to move us on for now then. Does that take us to enhancing patient experience? Have I done that? I have. Right, operational modernisation. This links to what we're going to be talking about later, really, doesn't it, in the business cases and the CIPs to corporate modernisation. Is that fair? Ross, do you have anything else to say about those 2 areas?
No, well, I think there's an awful lot of work that we're making good progress with in terms of investing to kind of transform the way that those operations work. So those business cases are a core part of it, particularly the first new ambulance deployment centre that we're working up the plans for at the moment. but also the real fundamentals of things like the strategic workforce plan that we need to get under and get mobilised.
Yeah.
Just really to follow up Sheila's point, on ambulance operations modernisation, this is very much where digital modernisation comes into it. As part it's a mistake, I think, to think of the ambulance operations modernisation as just being about transforming the way we work and the way we operate in all its forms, from scheduling and rostering, from logistics to vehicle management and make ready, as well as physical estate and geographic location.
Okay.
So it's as much about IT and technology as it is about hardwired old style infrastructure.
Okay. So, and then you've got enabling strategies, but I think what we need to do, unless there are any people wanting to disagree, is approve this as the business plan we're going to work to, approve it as the strategic themes that are going to be turned into objectives, which will be deliverable, measurable and quantifiable, sort of SMART objectives, but socialised within each of the divisions. So by the time we're looking at a plan for next year, each of the divisions has one that marries up to this. And when you talk to staff, they will know where they fit into that. They then do, if those are the themes, what does it mean to us and how do we make it real? Yep. Are we content to do that? Okay, so it takes us a lot further forward than we were, and we do recognise that the money is only now following on, which has made it more challenging. Are we content? Yep, thank you. Right, Anthony, I'm sorry we're running late for your item, patient and community involvement and engagement strategy. Hello.
Hi.
Over to you.
Thanks, Chair. So I'll assume colleagues have read the paper, which sets out the strategy for involving patients, carers, the wider public and local communities into our work, including a range of new, and I hope you'd agree, exciting initiatives. The board will be well aware of the importance and the benefits of involving patients and local communities. It's also enshrined within the NHS Constitution. The strategy has been developed in conversation with a number of organisations and individuals, including Healthwatch England, in case people don't know, is the national champion for people using health services, as well as the new London Ambulance Service Public Patients Council, Dame Chris Beasley, who is the chair of the council, but also former Chief Nursing Officer for England, and also our commissioners, NHS North West London Collaboration and Clinical Commissioning Groups. All have provided input, but also very positive feedback about the strategy itself. The strategy builds on recent developments, including the launch of the council earlier this year, as well as the Mike Cook report, which the board reviewed and approved at its July meeting. The strategy includes 7 priority areas, which, as well as covering a wide range of themes, will maximise the number of organisations and individuals we can involve, but as ever, remembering the importance of quality over this includes hearing from and involving the broadest range of people, especially those from seldom heard groups. I won't go through the 7 priorities, but key and I think exciting would be obviously the embedding of the council, now only a few months old, agreeing as part of that a work plan for the next 3 years, which aligns to LES priorities, and setting up a number of subgroups where they can focus on more detailed areas of our work. Second would be the launch of the London Ambulance Service Youth Empowerment Squad, which is made up of young people, which will help us get other young people to share their views with us. We're already in conversation with Bart's NHS Trust on this. They have a very successful youth group. And the third, I would say, would be key is working with Healthwatch England, local Healthwatch, and the London Ambulance Service Public Patient Council to develop a visits programme which gives accredited groups access to our services staff and managers so we can obtain constructive feedback and respond. I'm conscious that time is short, so I won't go into much more detail. I commend the strategy to the board and obviously welcome questions.
Anthony, thank you. Really pleased to see this. Rommel.
So very supportive, as you've just said, Chair. Thank you. Just one question, Anthony. Regulators as a stakeholder group seem to be missing.
So we wouldn't, I mean, obviously, we would involve the Care Quality Commission and others within our wider work, but in direct work in terms of work with public patients, I wouldn't necessarily see them being involved there. However, we have invited the Care Quality Commission to come and observe the Public Patients Council and NHS England and others. We've already had observers from Healthwatch England and also from our commissioner.
Yeah. Other questions for Anthony? Karen?
Just a comment that I think it's important to recognise, that this is a very important step forward and is actually a very well structured step forward, which goes beyond that which is in place in many other trusts, especially ambulance trusts. So I think it puts us in a very good place for the future. And I think it's entirely appropriate that this is about patients and stakeholders and not the regulators. So I think the structure is appropriate.
Yes. And will there be points which you wish to bring the chair of the group to our board meeting, Anthony, to feedback directly? Is that the plan?
Yes, so the intention was that when we have every meeting, that after the notes are agreed, that then we would invite Dame Chris and the co-chair to the meeting to be able to present the paper, present the notes as appropriate, and take questions and feedback. And obviously the council would welcome your attendance and Garrett's attendance at appropriate meetings too.
Okay, that's fine. Sheila.
Sorry, Anthony, I agree. I think it's a great step forward and very supportive. There was just a specific comment, and I had to take it offline, around the establishment of the longer-term EPCR advisory group for patients and public representatives. I'm not cited on that. I don't know whether I need to be as part of the D99 assurance group, but perhaps you could catch me up on that offline.
Yeah, for sure.
Okay, thank you. So I think we're all delighted to see this paper and to warmly endorse it. Thank you, Anthony.
Thank you.
Okay, thank you very much. Good. That moves us on to the Trust response to Black Lives Matter. And Garrett, you're taking this on your own or on your own?
Rosenblum in if we need to answer any.
Will you tell us? Okay, fine. So over to you.
Present it really myself in Ali's absence. So obviously we have been focused as an executive and indeed a board on redoubling our efforts to tackle racism and improve equality, particularly in relation to black staff, but also in relation to all minority ethnic staff across the organisation. We adopted a specific Black Lives Matter action plan earlier in the year, I think at the July board, and this paper brings an update on the actions that have taken place to deliver that over the last couple of months. I think specifically of note is the core leaders sessions that we have run for, it says 630, but it's now over 700 frontline organisation. These are online sessions of between 70 and 100 people at a time, with breakout sessions, facilitate breakout sessions of 7 to 8 people, led by myself and or Kadir if I'm unable to attend it, and our diversity consultant who has been Melissa Barry, as you all know, predominantly to really engage with our frontline managers to get them talking about issues of race and racism, get them comfortable with talking about it amongst themselves and therefore comfortable with engaging with their staff. I think one of the big learnings for us around Black Lives Matter was that whilst we have made a lot of progress as a trust in terms of getting all the right policies and all the right initiatives in place in relation to our race equality strategy, our res standard and so on, what we hadn't achieved was breaking down some of the taboos in the organisation of people being comfortable to talk openly about issues of race at all levels of the organisation. We have this discussion at the exec team and as well, and wanting to make sure that we get the whole organisation comfortable to engage, because it's only by doing that that we can start to address some of these more implicit issues in the organisation. People, do or don't realise some of the things that impact on them. So these sessions, I think, have been very effective and also been welcomed by a lot of staff, a lot of our managers. So this is frontline staff down to clinical team managers and watch managers in EOC and so on, who can then have a greater degree of comfort and confidence to be able to engage and talk on race issues. And I've been out going around ambulance stations and control rooms and so on, and actually being engaged now by managers and frontline staff on issues of race directly because they feel more comfortable and confident to talk about it. So I think that's been a really good short-term positive coming out of the action plan. The other thing I'd just highlight is the work that's going on to develop a specific action plan in integrated patient care. So that's 999 and 111 services, where we know we have more Black and minority ethnic staff, and therefore we have a greater priority to transform our workplace experience. So that work's been going on now. We have brought in addition to our own diversity consultant, John Bruder, who is the former chief executive of NELFT and the current soon-to-be retiring NHS London head leading up the diversity challenge there. He's got some spare time and is supporting our managers in 111 and 999 to develop a much more granular action plan to tackle some of the issues, which leads us on to obviously some of the particular cases that we've had highlighted over the last 2 or 3 months. That there's been some discussion in the board about around making sure that we are dealing with any disciplinary or grievance processes quickly and effectively where they relate to race in particular, which is something that we've also done. So I think those are the main areas of progress. Obviously, the action plan has a considerable degree of detail in it, and I'm sure members of the board will want to ask questions specifically on that.
Just to add to that, you will have seen in the action plan that there was an action for me to write from the board. I did. That was attached to my board report. It did result in quite a wide range of people contacting me, not just people from a Black or ethnic minority background, but people with wider diversity issues to have conversations and to garner support. And there is a feeling now that they can speak up, which is helpful. But as you know, in Part B, we will look at some individual cases, which wouldn't be appropriate to do here, that caused us specific concern. So we can pick up there. But there is a lot of work to be done. We are at the beginning of a journey, I think one could say. Are there any specific comments on the general report? Amit?
I think I've made this comment before, Chair, but I think really good to see a lot of progress against a lot of these specific actions. I think it would be useful to know how we're going to track the outcome of this, the impact of it. So do we have a measure in place, whether it's through our, the new staff survey we're doing about who we think we are, or some method of actually making sure that the delivery of these actions is impacting over time on the experience of our staff, whether it's experiencing racism or viewing racism. And I think that bit for me is still missing. How are we going to know that these things are delivering the desired outcomes?
You're right, you did raise it before, Garrett.
I think there are some very clear metrics in the race equality standard. There are 8 measures. 4 of them are derived from the staff survey, and 4 of them relate to people metrics specifically. So they're the most obvious ones. They relate to around equality of opportunity, around career progression, around likelihood of Black and minority ethnic staff entering the grievance process, and so on. We can obviously break those down into different parts of the organisation, and we see differences around those issues and around key indicators in the staff survey around things like bullying and harassment and so on. So there are a number of metrics that we can use to monitor where we're making progress, and obviously they relate closely to the areas where we're prioritising action in the first place. That's why we'd be focusing on EOC and 111 for more detailed, granular work first.
I just wonder if it might be worth thinking about supplementing that with something a bit more frequent, because I think with the staff survey, for instance, the sort of annual cycle means that you sort of take some actions and then you wait for, there's quite a long lead time and lag time with the staff survey. Maybe there's, given we have our own staff surveys that we're doing internally, there may be an opportunity to sort of supplement the national annual survey with something a bit more.
Well, we do pulse surveys and so on. So there's the opportunity to look at specific issues in specific areas of the service. So yeah, where we've done something specific, we can look at whether it has an effect. I think, you know, probably what we've got to do is get a little bit more sophisticated about understanding what it is that we need to do and what the issues are and what will address them, and then monitoring staff's sort of reaction to the initiative and to the actions, as well as the sort of longer term outcomes around overall well-being and engagement in staff survey metrics. So there's a deal of work to do there, and I think I would say that one of the big parts of this is actually strengthening our capability to do that, and the team we need to do that, because we need not only diversity specialists and equality specialists and so on, but actually we need some analytical capability to be able to understand what some of that data is telling us, and that's been quite a challenge over the last 2 or 3 months. And you know, a lot of the data that we have brought to the board has been hard won, shall we say, in terms of getting it to a point where we can have a sensible conversation. So we need to get better at that as well.
We have an opportunity to discuss some detailed cases in Part B that are about individuals, and we might pick up whether there's some lessons from that could help us. But I think what is being recommended, that we seek to find assurance that what we're doing is making progress, particularly in those areas that we know have a very difficult situation, and we know where those areas are. Yeah. Okay, thank you for that. So moving on then to the COVID lessons learnt, an important piece of work given where we are on the potential spike that is coming our way. So Ross, is that you then?
Kadir's going to take us through this one.
That's fine, Kadir. Briefly.
You're on mute, Kadir.
Schoolboy error. Thank you. Chair, the document is really for noting, and so thanks to Ross and team for pulling together various strands across the organisation in terms of both capturing everything that took place, but also then a number of internal workshops that have taken place at various levels of the organisation, just to review in terms of any lessons learned and any things that we can take forward in terms of best practice. I think it's hopefully well documented now, the extraordinary challenges that the organisation came under. One point that I think I haven't yet got numerical evidence of this, but I truly believe that the LAS is probably the organisation that's come into contact with the largest number of either COVID confirmed or COVID suspected cases, probably in the UK, given that we were in London, we're a London-wide provider, and we were right at the forefront of the impact of the first peak. So I truly believe that actually we probably have been in a unique position in terms of our experience of COVID and the extraordinary pressures that we came under, and the actions that we put in place to respond to it and rise to it and come through it. And I think it's a testament to the organisation at every level in responded to it. So I won't go into the detail of that. That's here in the document for noting and for recognising. I think the bit that I'd captured in terms of some of the lessons learned, which are on under 1.4.1, is just thinking about the reality that as an organisation, we are well versed and well prepared to respond to a major incident, and respond to a major incident that often take place in a very, very short space of time. And after, our responses are often magnificent. This was very different, and I think it's very different for the NHS and more broadly. It was a prolonged business continuity incident, and I think the lessons that we take away in terms of how we respond to that going forward, how we organise ourselves in terms of command and control at board, executive, and then at operational level, and how we then communicate and engage both with our partners and our staff, and how we ensure the welfare. Lots of lessons, lots of good practice came out, innovative good practice came out through the process that it's really important that we build and maintain, as opposed to reverting back to perhaps a BAU that doesn't reflect the world that we're now operating in and the pressures that we will continue to remain under.
Thank you.
That makes sense. Yeah.
Thank you very much. Are there any questions for Kadir? Fergus.
First of all, apologies for disappearing from your screens earlier. Normal service has now been resumed, I think. A question related to a matter that we have discussed in the past, which is around clinical decision-making, prioritization under pressure in extreme circumstances.
Yeah.
And I know, Chair, that you've talked about three wise men, we've talked about ethics committees and those processes. And I just wonder what the lessons are in that respect, and whether we've now taken on board the conclusions from the work that was done in that area.
I think, is it worth me asking Fenella to lead that answer?
Yeah. Fenella.
Thank you, Fergus. So I'm going to answer one part of it, and then Tricia will answer the second part of it. So with regards to approving pathways which have been written, we have got a system in place whereby they are taken through the patient safety clinical effectiveness group and into the London Ambulance Service Clinical Advisory Group, so that we have assurance that all of the right partners have been involved in approving that pathway, and we have been able to operationally model any changes that are going into place, and the clinical education and standards are able to provide assurance around any additional training that needs to take place. That can be done rapidly. However, there were times, as you highlight, during the COVID-19 first peak, where the speed with which the situation in London particularly was changing required us to have a slightly faster approach to be able to respond to national guidance as it came out, often changing on a 24 or 48-hourly basis. So Tricia will just talk through the process that we've put in place to provide that assurance.
Thank you.
Thank you, Fenella. Yes, as you know, this wasn't business as usual, and our business as usual governance processes weren't timely enough in relation to making very rapid decisions. So we've introduced what reflects a three wise man approach, but really this is about making sure when we have to make any rapid decisions, either operational, quality, clinical, that we always have the sign off of those decisions by two executive directors who are aligned to that particular function, and that we have an exec director sign off as well. So where possible, we will put it through our usual governance processes. Where the timing doesn't allow, we will then take it through our subcommittee non-exec representatives to have sign off, so that's minuted, and we can record those decision making and the rationale around it. So we've tightened up that part of the process.
Tricia, you meant clinical non-execs, didn't you?
Yes, sorry.
Yeah, thank you. Yeah. Okay, thank you very much.
That is now currently working.
Excellent, thank you. Any other questions? Clearly, lessons learned are very important, as I said at the beginning, because we move on to our planning going forward for winter. Are people content with the lessons learned? Yes? So thank you for that, really important. Okay, moving on to managing our strategic risks. Simon.
Thank you, Chair. So the enclosed paper sets out our strategic risk framework. There are three points for decision for the board today. Just to say, this has been routed through the Audit Committee. The first one is a recommendation from the Audit Committee that we approve the new format of the Board Assurance Framework. This is a new kind of industry standard recommended and recognised by KPMG and NHS providers. The second point for decision is to a recommendation from Ali Lane-Smith, our Director of People and Culture, to increase the residual rating for BAF Risk 56 relating to a sustainable workforce, increasing that from a 12 to a 16. And just to make the board aware, the chair of the People and Culture Committee, Jane Mee, supports that increase. And then BAF Risk 54 is one really for discussion and decision relating to KPIs within the 111 IUC contracts. As I understand it, this is a bit of a historical BAF risk. I think there is an agreement that the current wording isn't right, but what we do with that going forward is up for discussion. Do we remove it, which is a recommendation of the executive, given that we don't have the contracts as yet in relation to 111, or do we just reframe this around the financial risk that it poses? So that's a question for the board, Chair.
Thank you. So taking those three separately then, are we content to approve the revised framework for the BAF as recommended by NHSEI and KPMG? Yes? Do we agree with Jane and our Director of People and Culture that we should increase the residual staffing risk from 12 to 16? Yep. So this other one, I think, is a good example of board working where the exec have one view and non-execs have had a different view linked to the audit, but that might have changed in the light of income coming. So I'm going to ask Romuald to kick off with your view on this, and then Fergus.
I think I'm still in a place where there is risk associated with our finances. So until we get more certainty on that, I'm not in a position to recommend changing it.
Okay, and do you think the wording reflects what it should say, or should we revise the wording? I just need to come to others.
I think we should revise the wording.
Okay, thank you. Fergus, are you in that place or a different place?
Sorry, Chair, I thought the question was around 111, but in terms of a finance risk.
Sorry, it is about 111, that's what you're referring to, but there's a financial risk linked to 111, I think was your point, Rommel. Yes.
Because I suppose my perspective is that the context has changed in the sense that we're not contracting separately for 111 and 999. Lorraine will have to perhaps give me some backing on this. What I think is clear is that there remains a risk of not achieving our break-even objective. And that, I think, was touched on earlier. So if that's the issue, I think we should still leave it as a red risk, the finance risk. Whether that's a specifically 111 risk, I'm somewhat agnostic, given the new arrangements.
Right, let's just thank you for that. Amit, do you have a view?
Yeah. On the risk, I think the risk as currently stated around KPIs for 111 IUC doesn't seem to, it certainly doesn't seem to make sense to stay on as that risk. I think if we are going to keep a BAF risk on, I think what Fergus is indicating around a general finance risk, given the uncertainty until that's resolved.
Which includes the 111 element of it. I think that the history of the 111 is that we didn't have an affordable service, which we were slow to recognise and manage. And the question is, have we got one now?
111 and integrated.
Yes.
Is 111 and integrated care and understanding the cost of that service.
Yeah, and do we really do that? So Garrett, you wanted to come in?
Heather, I thought it might be useful if I put the executive view on this and why
I was just going to ask you,
why we think this risk should be removed, and it is, I think, precisely from the point that Fergus has raised, is that we do not have a financial risk or a contractual risk related to specifically to 111 services, because we have no contract at the moment and no funding stream for these services in the way we did have when this risk was identified. That's not to say there isn't risk around in the system. That's not to say there isn't risk around relating to our overall financial envelope, and we can discuss that and so on. But that is not this risk. That would be a different risk that we probably need to articulate directly relating to our financial position. So the executive's position is that risk 54, as it's currently drafted, doesn't really exist anymore. But that's not to say there might not be other things that we need to articulate around our financial risks.
So the difference that I am spotting is, I think, the agreement is BAF risk 54 does not currently articulate the risk as we have. The difference is whether we still have notwithstanding that we don't have a separate contract for it, or indeed any contract, that there's a financial envelope for the whole lot, there is a risk of our being able to deliver 111 in what would be an efficient, effective and economic way. That's how Rommel would put it, and I have to say I think that's where I am. So if it could be rewritten in that way, which is more financially and quality outcome evidence, I think I would be content. What do others?
Yes, please, Chair.
I think from an executive point of view, and Kadir might wish to support me on this, that the risk as conceived at the time was around our inability to recruit sufficient numbers of staff, partly to be able to deliver the levels of performance that were specified in the contract. Those levels of performance are currently not specified, but we are delivering the levels of performance that are specified and required, and we are in a much more sustainable position, as Kadir referred to earlier, in terms of substantive staff than we were when this risk was identified.
But just before Kadir comes in, I don't think he was here at the time. The risk was that we always recognised that the contract had to, we went into it on the basis of the first contract, it would be affordable and deliverable within a 5-year period, that it couldn't keep taking a loss, and that it was heavily dependent on GPs, which was not an affordable model. And I don't know that we have heard that we're convinced we have a model that's affordable or deliverable. Other than noting if we were to do more, we wouldn't be doing the clinical aspect, so we wouldn't be adding to the risk. Kadir?
Well, so just to support Garrett's point in relation to the workforce challenges and don't exist in the way that they previously perhaps did, and that builds on your comment too, Heather. I suppose my only challenge, and I don't want to prolong this, and I will go with the majority view, is that challenge in relation to affordable, efficient, etc. could be a challenge we could articulate across the entirety of services we provide, both in the 911s and non-ambulance services. But I recognise the history and the context. So I will work.
Let Lorraine come in, and then we're going to have to form a view.
Yes, thank you, Chair. I would agree. I think if we're talking about this year's objectives and for the reasons that Garrett and Fergus have raised, I don't think there is the risk, but I do think we should be looking at the whole impact of moving into different services, transforming our operating model. I mean, the impact of COVID has had a fundamental sort of changes. So I think there's something about describing that risk to our kind of 5-year sort of sustainable plan. But I suspect that will be picked up in the specific big, large programs. So I think I do support. I support, potentially re-articulating this as a wider risk to our overall sustainable model. But I don't think I support the specific in-year risk for.
Okay. So I think we're all agreeing that the specific risk, as articulated, needs to come off. But at least Rommel and I would like to replace it with one, which I think you and Kadir have started to articulate. And I think my question to Rommel in particular is, could that cover it?
Yes, Chair. Yeah. I think it's about the strategic delivery of this service and sustainability of the service.
So what I think we're asking for, therefore, are people in agreement that this risk comes off, but that a new one, we ask the executive to go away and assess the rating of the risk, of the strategic risk of delivery of our services in the transformation that we've got with the resources we have available, whether it's manpower or money, and come back with what that is. Does that suit people? And can I just have a show of hands if that now meet? Oh, Fergus, you want to come back?
Yes, I just want to be clear that we still have an overall financial risk in the package of risks. I'm not quite clear where that is.
Where is he?
You mean add one, Fergus, an additional one, an overall?
I mean, it seems to have been sort of part of COVID multifunction risk.
Yes, it's one of the subcategories of the COVID risk.
Financial risk assessment related to the COVID one, but I think, are you suggesting we have an overarching trust?
Well, Yeah, of course, we're in a new environment now, but it seems to me that there is a risk still of not achieving break even, whether from COVID or winter pressures or indeed inadequate funding.
Could I just come in, Heather?
Yeah,
I think we have previously had on the BAF risks a risk that related to achieving our control total in year and so on. Obviously, at the end of last year, that came off, I believe, because we've achieved our control total. I think what we're articulating now is that there is a strategic risk related to our ongoing finances around our ability to deliver a sustainable service and deliver it to the standards required, and that extends in part to this year in terms of the outstanding uncertainty over funding, which is now much smaller than it previously has been. But it does extend much more to the longer term about our ability to transform our services economically, deliver efficiencies, and sustain the levels of performance and levels of service and levels of patient care that A, is required of us, and B, we're currently able to do.
So I think where that leaves us is two BAF risks. One, a short-term one, which is the financial one you allude to for this year, and then the replacement of the 1111 with a broader one about transformation that will include the 111 and needs to be articulated. And if the executive could come back and offer us up some wording, which probably could be looked at both FIC and Audit, I think that resolves it. Would it resolve it for everybody? Can I have a show of hands, please? Mark, yep, no dissenters. Okay, I think we're in a good place. I thought I was going to have to go for a vote, but we've resolved it, thank you. So we look for, when will we see that, please? I think that shouldn't hang around. Can we do it in correspondence? Did you want to ask a question as well, Karim?
Yes, about the BAF, a different BAF risk.
Okay, a different BAF risk. Off you go.
I just wanted to quickly ask about the catastrophic IT failure risk. It says in the papers that it's gone up in that table, but it doesn't look like it has. And also, I was wondering, given everything that's been done with the new CAD and everything, why it's going up and why will it ever go down?
Okay.
Sorry, it's a bit vague, but it didn't quite make sense to me.
Fair challenge.
The board approved the increase at the last meeting, so that the board's functioned on that. But Kadir or Sheila might want to come back on
So Sheila and Kadir, briefly.
Have a comment.
Yeah.
Yeah, it was. I think this is historical. I think it was 2 meetings ago we approved to increase it, because if you recall, Karim, at that point, we had identified a number of infrastructure-related challenges with Barry coming on board. I feel that we should start seeing a trend downwards on that, and it's something I think we should review at the next Logistics and Infrastructure Committee, because as I mentioned in my report, we have got some evidence now of good progress being made. I'd recommend we take it at the next lick, and have a look at it then, and I would expect it to come down.
Okay, thank you. You could, Kadir, yes, okay?
Agreed, yeah.
Right, thank you very much. That's what we should do. Thank you for raising it, Karim. Okay, so that now brings us to any other business. That's a no. So just to summarise briefly what we've covered today, a wide range of discussions, but I think importantly, we have had an update on the money available to us for the rest of the year, which we will be discussing more, which has allowed us to approve a business plan that needs some measurable objectives, that needs socialising, but it is over a 3-year period, which is helpful. We've had some assurance around where we are with logistics and 999, and indeed in audit and finance. The capital expenditure programme was approved. The financial plan for 2021 was approved. We were very pleased to see the engagement strategy. That is really good work forward. We've had an update on Black Lives Matters, and we've had both lessons learned from COVID and a degree of assurance on winter, COVID and flu, with lots of reassurance, but more assurance to come with significant challenge, but all good work. So if there are no other questions, I would like to thank members of the public for joining us. We have no questions as is today from members, but if we do get them, we will answer them in correspondence. And that brings us to the end of the meeting in public. Thank you very much. Thank you.